Hello and welcome, everyone. My name is Kristen Talbot. I'm the program manager for MAVEN Project. Thank you all for joining us today, and our friends at Tri-Cities Community Health for hosting today's session, Assessment of an Abnormal Liver Test with Dr. Philip Styne. With that, I'm going to share screen and I will turn it over.
Good morning. Hi. My name is Phil Styne, and I'm a somewhat retired gastroenterologist and hepatologist. I am currently in Orlando, Florida, so I apologize for my relaxed appearance because I'm in the midst of getting ready for a little hurricane that we're going to supposedly have here in a couple of days. Okay, to disclosures, I don't have any financial disclosures to reveal, and this program is accredited through ACCME for Category 1 credits. It is not my goal to have you treat all liver disease. My goal is to raise your knowledge, increase your diagnostic ability, and help you make educated referrals when appropriate to a partner, a hepatologist that hopefully you can find in a relatively nearby community. I will point out to you, though, that we have hepatology consults available for you through the MAVEN Project, and I am actively a part of that with several of my colleagues. Next slide. Okay, what are liver tests? A lab value that reflects possible liver injury or dysfunction. The common term liver function tests are, for the most part, not a measure of function. Scans of the liver, ultrasound, CT, MR, all probably well aware of those. Some other scans or non-invasive tests that can be useful include some calculations, one called a FIB4, which is a calculation that you can easily make and can give you some hint as to whether or not there's potential for significant fibrosis in the liver. Elastography you've probably heard about, called FibroScan, and also MR actually has a way of doing a measure of fibrosis. Liver biopsy and measures of vascular pressure, invasive procedures with some risk, but sometimes we go to that, but that's probably going to be something more that the hepatologist that you might refer a patient to would be using. Next slide. So let's talk about some specifics about these liver injury tests. AST, high concentration enzyme within hepatocytes, but it's also a lot of other places, especially muscle, brain. ALT is a little more liver specific, but also it does occur other places in the body, and both AST and ALT are released when the hepatocyte is disrupted. Alkaline phosphatase is completely different. Alkaline phosphatase is an enzyme which appears on a small portion of the hepatocyte membrane where the bile canalicula is next to the hepatocyte. It is inducible, and what that means is that in certain conditions, it will increase in amount and therefore increase in the blood. The things that increase alkaline phosphatase are pressure. That pressure could be local, such as a tumor pushing on that portion of the liver of the hepatocyte, or it could be on the bile duct, either in the liver or outside the liver, putting pressure again on that section of the hepatocyte membrane and inducing elevation of alkaline phosphatase. Gamma GT is sometimes used to confirm alkaline phosphatase. And another point that I'll make is in most liver disease, the ALT elevation is much greater or greater than the AST, but in alcohol, there's an unusual situation where the AST is oftentimes significantly higher than the ALT. Next slide, please. Bilirubin, breakdown of hemoglobin, which I'm sure you're all aware of. It has so many factors it can cause elevation. But I think the most common thing to do when looking at a bilirubin is to see if the majority of it is direct or indirect, especially in patients who have low levels of elevation of bilirubin in the, say, 1.5 to 2.5 range. If it's a lot of it is indirect, certainly think of either hemolysis or Gilbert syndrome. It's spelled like Gilbert, but the guy was French, so we'll spot him on that and call Gilbert's, which is a common situation. It is a metabolic anomaly. It is not really a disease. So Gilbert's is out there. Some things make the bilirubin go up in Gilbert's, for example, fever. So a lot of times you'll see isolated mild elevation of bilirubin, and the first thing you want to do is split it and see how much of it is direct or indirect. Prothrombin time, again, lots of factors can lead to an elevated prothrombin time, but in patients who you think are having significant liver injury or potential liver failure, a rising PT-INR that doesn't correct with vitamin K can be a significant measure of liver dysfunction. Albumin also produced in the liver. So many factors affect level, hydration status, calorie intake. So it is of note if the albumin is low, but again, a lot of reasons for the albumin to be low that may not be directly related to the liver. Next slide. So I like to break down liver into different diagnosis into some files, some packets. Infections, which is certainly going to include viral, very common, some parasites, occasionally bacterial infections in the form of abscesses. Ingestion exposure, and I use ingestion exposure to include medications, including prescribed medications, okay? But it also includes all kinds of food products, food additives. I just had a patient with abnormal LFTs taking some huge amount of turmeric a day. Like, I guess you can go to, a health food store and get turmeric capsules, and they were taking 10 turmeric capsules a day. We stopped it and the LFTs got better, so I think that was a diagnosis. And exposure are environmental exposures. Fortunately, the majority of environmental exposures have been reduced. For example, the famous one that really our parents had a lot of exposure was carbon tetrachloride, which was used as a common household cleaning agent and was highly toxic to the liver. Metabolic includes important diagnosis of hemochromatosis, which is iron overload, inappropriate establishment of iron absorption and copper. Autoimmune disease, both a direct autoimmune hepatitis where the liver is the main focus of the autoimmune disease, but we also see liver effects in more systemic autoimmune diseases such as lupus and occasionally rheumatoid arthritis. Pregnancy is important. Pregnancy and abnormal LFTs can be a very serious condition and needs to be thought about. If you see a actively pregnant woman with abnormal LFTs, this is a big problem. And I think almost virtually every time they need to be referred to hepatology. There are potentially life-threatening illnesses that have very, very serious decisions to be made about the pregnancy. Systemic illnesses, we see abnormal LFTs. I'll throw out one just for the fun of it. celiac disease, okay? Thyroid disease. Another one people rarely think of is renal cancer, renal cell cancer. And vascular disease, uncommon that you're going to see in a primary care setting. These are either patients with vascular collapse, such as a code, or vascular catastrophes where they're hypercoagulable and clot off major vessels. So not likely to be seen in the outpatient setting, and they can present, though, fairly dramatically. Next slide, please. Okay, so there's a lot made about patterns of liver injury, hepatocellular versus cholestatic. Sometimes it can be very helpful to divide it up. For example, viral illness almost always causes hepatocellular disease, except when it doesn't. I've seen one particular patient with hepatitis A who had a very cholestatic pattern. And when you look up drug toxicities, and we'll talk about that later, very often there's a mixed elevation. Do note, though, that bilirubin can be elevated in both the hepatocellular and the cholestatic pattern. Next slide, please. So let's talk a little bit about infections. Hepatitis A, acute, virtually never chronic, fecal oral. Hepatitis B can be both acute and chronic. In the adult, only about 5% become chronic. But in vertical transmission, babies' rate of chronic disease approaches 95%. Main reason why all pregnant women need to be checked to see if they have hepatitis B. C, causes acute and chronic disease. The acute disease is almost always missed. It's very mild usually, and very rarely jaundiced. And people think of all hepatitis C as becoming chronic, when in fact, actually only 80%. But on the other hand, it's 80%. But every once in a while, you will see somebody who had hepatitis C, didn't get treated, and doesn't have active disease. D is a fascinating disease which is seen only in patients with hepatitis B. It's an incomplete viron. E is actually often waterborne, very dangerous in pregnancy, and has been considered to be a third world infection. Was pointed out by one of my colleagues when I gave this talk previously, that there's becoming some concern about E. And when you do population studies, for example, looking in water in communities, and nowadays we're looking for COVID, in wastewater, there probably is more hepatitis E out there than we realize. And so the next, I got a thing, okay, and a variety of viruses. Next slide, please. Okay, ingestion. Prescription drugs, a drug-induced liver injury is very common, oftentimes mild, but sometimes not. For example, statins. It's very common for statins to cause 2 and sometimes 3 times elevation of AST and ALT. But every once in a while, you'll see a patient who got a statin and got horribly sick. Over-the-counter drugs, probably the most common one that you see is acetaminophen. Acetaminophen as a suicide attempt, but occasionally you'll see somebody, and especially in alcoholics, so they're drinking a lot of alcohol and at the same time taking acetaminophen, and especially now that we have a very common extra strength Tylenol, acetaminophen, you have to think about it. Supplements, and I bring this up all the time, you got to ask people what they're taking, and you'd be surprised at the things that people do. Anabolic steroids, I probably see a young male taking bodybuilding, muscle building that they got at some health food store, and they're in my clinic and they're jaundiced. And I mean, they are bright yellow. Remember, they were bulking up so that they could get a hot date. Kind of tough to get a hot date when your eyes are yellow. Just saying. Toxins, mushrooms. Fortunately, I haven't seen it in a while, but there are toxins that people get into. If you work in a city with a lot of industrial plants, I spent some time in Houston, and we used to see people get toxin exposures at chemical plants. It happens. Most commonly, these are hepatocellular pattern, but they can be cholestatic. And they certainly can be cholestatic if it's drug-induced liver injury. Next slide. Metabolic. Okay. Right at the top of the list, okay, as everybody's talking about it because it's very real, and I'm in the process of coming up with a talk about steatotic liver disease, what we used to call fatty liver disease, okay? We've changed all the names. Non-alcoholic fatty liver disease is now metabolic associated steatotic liver disease. NASH is MASH. It's out there. Probably 30% of our population has the potential for steatotic liver disease. Hemochromatosis is common, and it needs to be looked for. Good screening is doing a ferritin and iron saturation. Wilson's disease, copper accumulation is fortunately not uncommon, but it needs to be thought about, especially in young. Alpha-1 antitrypsin disease I bring up because we now have some treatments for it. It's almost always you're going to see patients with pulmonary disease. There are a variety of anti-alpha-1 antitrypsin genotypes, and some potentially produce more liver than lung or lung than liver. But getting an alpha-1 antitrypsin level is an easy screening. Next slide, please. Autoimmune disease we mentioned previously, autoimmune hepatitis, usually sick patients. When they have autoimmune hepatitis and really it's quite ill, they're systemically ill. And they have high enzymes, systemic symptoms, oftentimes female, young to middle age. Again, association with other autoimmune disease, rheumatoid arthritis and lupus. And then a couple of autoimmune diseases which are fairly uncommon, but you should be aware of. Primary biliary cholangitis, which we used to call primary biliary cirrhosis, but we've changed the name because we're making the diagnosis much earlier. Cholestatic pattern, very high alkaline phosphatase, rising bilirubin, minor transaminases, more common in females. And the other one I didn't even put on here is primary sclerosing cholangitis, a extrahepatic bile duct inflammatory disease, usually associated with inflammatory bowel disease, Crohn's disease, and ulcerative colitis. Next slide. Okay, systemic diseases, again, I just mentioned IBD, celiac disease, thyroid, metastatic cancer. Metastatic cancer causing cholestatic-like pattern could be of any source, lung, breast, pancreas common. Sepsis, you can see from some pretty significant abnormal LFTs, but these are people who are sick, very 4+ sick with sepsis. And granulomatous disease always needs to be thought of in the cholestatic patient. And I just lost my screen. Christine, I just lost my screen. Oh my God.
I understand.
Okay, next slide. Let's see where we are. Next slide, one more. Okay, and here we go. Vascular disease. Again, I think that these are going to be relatively uncommon. in the private practice, in the outpatient setting, congestive hepatopathy, for right-sided heart failure, ischemia post-Crohn, Budd-Chiari is thrombotic event of hepatic vein. Okay, next slide, please. Okay, directed history. A lot of times one of the first thing that happens to me is the patient gets sent to me with some abnormal liver tests. And the first question I have is, why was the lab drawn? Was it drawn as just a regular routine lab? In a primary care setting, you might get a CMP just as a screening, but on the other hand, you may have gotten it because of some symptom, and paying attention to what that is. A lot of times, especially in viral hepatitis, arthralgia. I get a patient every few months from a rheumatologist who was seeing the patient for acute arthralgia, and they have acute hepatitis A or B. A birth history is important. Meds and over-the-counter and food supplements, I can't stress this enough. Surgery and or transfusions, supplements actually probably belongs up in the other section. And then high-risk patients, IV drug users, work, travel, incarceration, really high rate of viral hepatitis in the incarcerated population. Past history and family history, especially family liver history. For example, you're seeing somebody, you have some suspicion that they might have hemochromatosis, and you find out that dad died of cirrhosis and he drank a little bit, but not a lot. Okay, maybe he had hemochromatosis also. So family history can be helpful. Next slide. And then the directed history for anything that suggests decompensation. Encephalopathy can be incredibly subtle. It's usually confusion, and confusion at a level of can't do my checkbook, got lost coming home from the grocery store, and then some more obvious decompensation such as ascites, bleeding, and the end-stage disease, which would be unlikely to see in your practice, but need to think of it. Next slide. Physical exam, BMI, again, we're talking about our steatotic liver disease epidemic, tattoos and injection scars, signs of advanced liver disease, jaundice, spider angioma, ascites, encephalopathy, asterixis I didn't mention. And next slide. Lab, some of this is pretty obvious, but let's go through it. CBC with a platelet count, a CMP, and a ProTime INR. Gamma GT, I actually don't order them hardly ever. Hepatitis A, B, and C markers. Let's talk about this a little bit. A lot of times, a lab will have what we're going to call an acute hepatitis panel. It's a good thing and a bad thing. So for hepatitis A, we have an IgG and an IgM. The IgM is what's going to be on the acute panel. The IgG will be positive. So if we want to know for future reference whether or not they're immune to hepatitis A, we want the IgG. Hepatitis B markers. So they're going to have a B surface antigen and a core. Sometimes the B core is total, and sometimes it's IgM. If it's IgM, that's okay, but we really want total because the IgM could be negative in chronic disease. Hepatitis C antibodies fairly self-explanatory. Iron studies for hemochromatosis, a alpha-1 antitrypsin level, ceruloplasmin for Wilson's disease, an ANA, and anti-liver kidney microsomal anti-smooth muscle for autoimmune hepatitis, and an AMA for primary biliary cholangitis. A drug level, depending on the setting, you may or may not want to get. I mentioned PETH because A lot of people seem to be unaware of this test, and don't ask me to give you the full name. It's the polyethyl something, something, something. And it's a PETH. And think of it as almost like the hemoglobin A1C for glucose. It is a measure of alcohol use over weeks and months rather than the 24 to 36 hours that an alcohol level will give you. So if you have somebody who you suspect of alcohol use that they're not being honest about, getting a PETH can be very, very useful, and it seems to be not a commonly known test. Next slide. Scans, ultrasound. If you're getting an ultrasound, please always get a complete ultrasound because it will show you spleen size, which can be a hint of significant chronic liver fibrosis and cirrhosis, and also look for pockets of ascites that may not be seen if you just get a right upper quadrant. A CT scan is often useful, especially if there's focal disease, and an MR and MRCP can be useful, but usually those are going to be ordered by the hepatologist or in conjunction with your hepatologist. I don't order HIDA scans very often. They are oftentimes misused, and I'll leave my editorial at that. Next slide. Non-invasive study. Okay, FIB4. FIB4 is a simple calculation, takes AST, ALT, platelet count, and age. And it's like a lot of tests, if it's a fairly low number, then you know the patient probably doesn't have significant fibrosis. If it's a fairly high number, then they probably really do have significant fibrosis. And then there's, unfortunately, a pretty good mid-size range. That mid-size range, though, is still something that should be paid attention to and can be used to decide whether or not the patient should be sent on for further evaluation. FiberSure is a set of proprietary serum tests, as is ELF. Elastography, done most commonly with a device called a FibroScan, is an office procedure that you're going to see a lot more commonly in the gastroenterologist, hepatologist office, and MR elastography, a fairly sophisticated and expensive test that probably is going to be more likely ordered by the hepatologist. Okay, next slide. So let's run through a few cases. You got a 66-year-old male, hypertensive, has a CMP done as part of a routine lab, and they're elevated. You're seeing the patient. He says he drinks a couple of alcoholic drinks a day. He drives a school bus. He's a retired policeman. He has hypertension. On physical exam, he has spider angioma, protuberant in abdomen, some lower extremity edema. He has a platelet count of 78,000. His AST and ALT are minimally elevated. His albumin is low. His INR is mildly elevated. Next slide. He has evidence of previous hepatitis A. Interestingly enough, he has evidence of previous hepatitis B. So he's surface antibody positive and core antibody positive. His hepatitis C antibody is positive. His hepatitis C RNA is positive. He has chronic hepatitis C with cirrhosis. Look at his ultrasound. Big spleen, coarse liver, some free fluid, so he has ascites. Next slide. He has advanced hepatitis C. He needs to be referred to hepatology, and coming into your venue as a primary care, he's got to stop driving the school bus. This guy is at high risk of having encephalopathy, even if it's hard to detect. Very common. And believe me, when I tell people they can't drive or they can't drive the school bus, they're not happy, but it's our responsibility. Next slide. Okay, so here's a 20-year-old, okay, referred from a drug outpatient program, okay. He has hepatitis C. He has evidence of previously having hepatitis A. Now let's look at his B markers. He's core negative and surface antibody positive. What does that mean? That means that he was vaccinated for B. He never had B. So the vaccine will give you a positive surface antibody, but the core will not be positive, okay? He has hepatitis C. His RNA, 2 million. CBC is normal. LFTs are mildly elevated. Next slide. He's too young to have advanced disease. He's not pregnant. He doesn't have active B. He's on no other drugs. This is a patient appropriate for treatment by primary care. I am heavy on recruiting primary care for treating uncomplicated hepatitis C. And I have a lecture you should sign up for. How is that for a sell, Christine? Okay, next slide. Fatty liver disease. So the powers that be decided to rename these, and you know, the idea of calling it fatty liver disease had some you know, concerns about the term fatty, so they changed it to steatotic. Non-alcoholic fatty liver disease is now metabolic dysfunction associated steatotic liver disease. NASH is MASH. The difference between metabolic associated steatotic liver disease and MASH is inflammation and scarring. Lots of people have fat in their liver, but don't have inflammation. It's the inflammation that leads to scarring that leads to cirrhosis. And those are the patients who need to be really looked at. They also added an additional group, which is essentially who have steatotic liver disease for two reasons. Probably because they are overweight, but they all drink too much alcohol. And that's something to be aware of. Next slide. And okay, so here's a 56-year-old female, mildly abnormal transaminases, type 2 diabetes, hypertension, elevated cholesterol. She's on metformin, lisinopril, not on a statin because her primary thought, because of abnormal LFTs, they didn't want to start a statin. Her physical exam shows a BMI of 36, no stigmata of chronic liver disease. CBC is normal. Acute hepatitis profile, all negative. Ultrasound, dense liver, normal spleen. Next slide. Okay, so likely has metabolic associated steatotic liver disease, but because of diabetes, they're certainly at increased risk for having MASH. Okay, so we calculated a FIB4 and it came out 1.26, which is low. So probably consider sending them for a fiber scan, but they're not high risk. So what would we want to do? If they can afford it, we want to change them to a GLP drug or a GLP-GIP drug. We absolutely want to put them on a statin, and we want to get them on a monitored weight loss and exercise program. In one of my clinics, there's a physical therapist, and I'm sure that 99% of her business that she would assume is rehabbing people with broken bones and strains and etc. I'm using her to create exercise programs for my steatotic liver patients. And it's really worked out quite well. I don't have a dietitian, and weight loss through diet, we could have several talks about it. I don't have a good answer for you. Next slide. Patients with MASH are at high risk of morbidity and mortality from collagen vascular disease, for cardiovascular disease. And for patients with fatty liver, unless they have fibrosis at 3 or cirrhosis, their morbidity and mortality is not their liver. It's cardiovascular disease and cancer. And so we've got to get on these people about weight loss. 5 to 10% weight loss, huge effect on their liver and also on their cardiovascular and cancer risk. Next slide. Okay, so this is the same patient, but a little bit different. So their platelet count is low normal. Their FIB4 is in this intermediate range between 1.6 and 3.6. They need a FibroScan to see how much fibrosis they have. They got to be changed to a GLP drug. They need to be on statin, and they may be a candidate. There is now a specific drug for metabolic associated steatohepatitis. I think it really should be prescribed by hepatologists, though it could be prescribed by you all in concert with a hepatologist. But again, in this patient, I'm pushing changing their treatment for their diabetes to something that will also produce weight reduction. Next slide. And that same patient, but now they have a platelet count of 95,000. Their FIB4 is absolutely abnormal. Their ultrasound shows a big spleen. They have cirrhosis with portal hypertension, almost for sure. They need hepatology referral. So there's an example of a steatotic patient going from mild disease to advanced disease. And we look to see how things like platelet count, FIB4, an ultrasound can help you parse out those different patients. Next slide, please. Okay. Hepatitis B is a little complicated. Hepatitis B has a lot more markers than C. So it's a little more complicated, but this is a common referral for me. Health department, surface antigen positive, no high-risk activity other than the fact that he was born in Haiti, which makes him at very high risk for having vertical transmission. Got a normal CBC, mildly elevated amylase, AST and ALT, no evidence of hepatitis C. He's surface antigen positive, core antibody positive, a DNA of 33,000. And the E antigen and E antibody, I'm kind of trying to show you that these decisions can be difficult. Next slide. Likely vertical transmission, decision to start patients on hepatitis B treatment is complicated. The reason is because the treatment is not a cure. It is a suppression of viral replication. And the idea is that by suppressing chronic infection, we can reduce fibrosis and also reduce the risk of hepatocellular carcinoma. But it is a treatment that needs to go on indefinitely. Patients on treatment can themselves convert to surface antigen negative, but that's solely a matter of their own immune system. It's not the treatment, unfortunately. There are treatments in the pipeline to rid people of hepatitis B. They're years away. Next slide, please. Okay. Don't copy this down, but Christine will make it so the slides are available. But this is a look at hepatitis B, acute and chronic. And you'll notice in the chronic line, they may or may not be surface antigen positive. So you can have a patient who's surface antigen negative, hepatitis B core positive, and have chronic disease. How do you know? By checking the DNA. Previous B, we talked about the core is positive, the surface antibody is positive. Previous vaccine, the core is negative, and the surface antibody positive. And I didn't even put the E antigen and E antibody on this slide to keep it from getting too complicated. Next slide. Okay. Here's a young female, generalized symptoms we talked about, high enzymes. Look at AST 2200, ALT 3100, mild jaundice, elevated gamma globulin as part of their immune reaction, positive ANA, positive anti-kidney microsomal antibody, autoimmune hepatitis. She's sick. She needs treatment. And treatment is immunosuppression, starting off usually with prednisone and azathioprine. I think almost assuredly somebody you're going to want to refer, or at least treat in concert with a hepatologist. Next slide, please. Similar patient, okay, all right, but they have non-small cell lung cancer. They're on a PD-L1 drug, and they have immune-mediated hepatotoxicity of drug. I see one of these every other month. Next slide. So this is a fairly common, again, this is a young man on a muscle builder, anabolic steroids. We talked about it. He has this mixed pattern of AST, ALT, alk phos, and bilirubin. And his hepatitis markers are negative. And he's got drug-induced liver disease. Next slide. And this is kind of obvious. Some of this stuff we prescribe every day and we don't think about. The anti-epileptics, we see oral contraceptives. INH, I see a bunch of, because I see a bunch of patients who are coming into the country and turn out to be quantiferon gold positive and need INH. There are cardiovascular drugs that we see that are common. So you got to think about drug-induced liver disease. Next slide, please. Oh, wait a minute. I think you went the wrong way. Go next. Let's see. Oh, I'm sorry. So this is an example of a young man who you think should have hepatitis C, okay? His hepatitis C antibody is positive, but his RNA is negative. And he says he was never treated for C. He's one of the 20% that get over on his own. But look what he does have. He has a ferritin, which is very high iron saturation. Next slide. He has hemochromatosis, okay? Very treatable with phlebotomy. Or another patient, similar, but his ferritin is high, but not super high. And his hemochromatosis genotype is heterozygote, not homozygote. And you do a PETH and it's off the charts. The diagnosis is a young man who's an alcoholic and doesn't admit it. Next slide. Urgent consults. We talked about pregnancy. Don't fool around with these people. There are serious decisions to be made that have to do with the life of mom and unborn. These are serious. Send them on. Comorbidities, especially in acute hepatitis. You'll see a patient, a diabetic, with acute A. They can't eat. Their diabetes is all over the wall, crazy, out of control. They can be a real handful. Worsening jaundice and acute hepatitis. See somebody with hepatitis A, they're not that sick. But I tell them, urine gets darker, eyes get yellower. You're on the phone to me. 2 days later, they're calling up saying, my urine is so dark, you think it looks like tea. They could have a big problem. Any sign of decompensation. Possible drug-induced liver disease from a vital drug. I probably see once a year a patient on amiodarone that they absolutely need, and their liver's doing bad. And potential ingestion. We have great treatments for acetaminophen. For mushrooms, well, not so much. For chemicals, depends on what it is. Mostly, those are people potential for a emergency transplant. Next slide. So a few added comments. please, I don't care what the liver disease is, I want to know if they're immune to A and B, and if not, they need to be vaccinated. And especially true with your older patients with steatotic liver disease. Know your practices high-risk populations. Mine, as you've heard, I get lots of referrals from the health department for recent immigrants. Get a hepatitis C antibody on everybody between age 18 and I don't have a top limit. And here's my last one. Find a hepatologist you can curbside and or use MAVEN Project resources. We're here I do a consult every week or so. Happy to do them. They're easy. You type it up. I type your answer. We go back and forth if need be. Next slide. The top thing here, LiverTox, this is a great site you can put on your phone, which will allow you to look up medications and see if there's a potential for drug-induced liver disease. There's MELD calculators. MELD is a measure that may give you some hint as to the degree of patient's liver disease. If you're talking to a hepatologist, having it a MELD calculated will impress him or her. I think you should all be doing FIB4s on anybody who you think has chronic liver disease, especially your steatotic liver disease. And a common consult that I get, and I think you may get, is some patient with maybe some mildly abnormal LFTs, some liver history, and the orthopedic surgeon sends you them to you for clearance. Okay. Mayo has a great post-op mortality risk calculator for patients with liver disease, and it's an easy downloadable calculator. And so you get these consoles, and it says, is a patient cleared for their hip replacement? And I write back, I don't clear patients, but I will give you their statistics. And I then just quote the numbers right out of the Mayo site. X% for mortality at 1 week, 30 days, and 90 days. And I just sort of send it back to them. Next slide. Again, we talked about MAVEN as a resource. And next slide. My contact information. And please reach out to me. Okay. Questions?
Thank you so much. We do have a bunch of questions. Hopefully we can
Okay.
get all of them. Let me just start with, I see lots of obese teens with borderline elevation of either AST or ALT or both. How high above normal do they need to be before I should do further testing or refer?
Abnormal. Whatever abnormal in your lab. And I will say that because most labs, if you talk to a hepatologist, most hepatologists are going to tell you that the lab's abnormals are set too high. Okay, you'll see 35, 40 as a high for AST and ALT. As far as I'm concerned, an ALT in a male or female should not be higher than 20. So my level that I worry about is much lower than most labs. So if you have a patient who has an abnormal LFTs on your lab, I think they absolutely need to have hepatitis A, B, and C markers, vaccinate if necessary. For a male, for sure, screen them for hemochromatosis. I am probably overly concerned about Wilson's disease because I've gotten burned a couple of times. I get a ceruloplasmin on anybody who has a couple of different determinations on abnormal LFTs. If they have a history of asthma, they need an alpha-1 antitrypsin. Okay, all right. Obesity in young kids is, I mean, it's, I know I'm preaching to the choir when I tell people in primary care that this is a problem.
What about PCBs? I understand that they may cause fatty liver. I only see increasing environmental toxins.
Um, yeah. Um, I spent some time in Houston where, environmental toxins are like everyday concerns for people working in chemical labs. Um, you know, uh, it's very tough. I don't have a straight answer for you. I think that toxins are out there. We need to try to keep our patients away from them. If they have abnormal liver tests, be all that much more concerned. I don't know. It's a non-answer answer. I don't have a better one.
That's fair. What reference range do you give for normal AST and ALT values?
Okay. To be honest with you, I kind of actually ignore AST. AST, sort of is the stepchild. ALT, I want to see an ALT less than 20.
Okay.
And again, that's not what you're going to see from your lab.
How does thyroid disease cause the liver dysfunction?
Okay, so there are thyroid receptors in your liver. Okay, all right. I know that seems really strange, okay, but there are thyroid receptors in your liver. In fact, actually, the drug that has just been released for treatment of MASH, not using GLP drugs, okay, is a thyroid receptor agonist, okay? It is increasing thyroid hormone activity on hepatocytes. So there's really, really interesting interaction between thyroid hormone and your liver. And that is the level of my knowledge. There are probably cellular biochemists who could do better than that, but that's the best I got.
Thanks, Dr. Styne. For acute hepatitis B, can the core IgG be negative? Should we get IgM?
For acute hepatitis B or C?
B.
B, okay, okay. Can the
Core.
yeah. So in very acute disease, the IgM is going to be elevated, okay? By the time they're symptomatic, the IgM is going down and the IgG is going up. So when I see somebody who has acute hepatitis, they're acutely ill, maybe jaundiced, okay, I will get a surface antigen, a B core total, and a B core IgM. And of course, I've gotten a hepatitis A IgM and a C antibody. So there's a crossover there from the IgM to the IgG in the C that occurs just about the time they're becoming symptomatic or a week or two after they're symptomatic, presuming that they're going to resolve the disease spontaneously. There are some patients who resolve the disease spontaneously, but it takes months, like 3 months. So in general, in B disease, we don't call them chronic until they're sick for 3 months. And that's a little different than an A. A, you should be over it in 2 to 3 weeks total. Okay, sorry.
All right, next question. I work in an area with lots of prenatal Hep B transmission. At what age should we start screening these kids?
Okay, say that again. I'm sorry. So there's a lot of potential for vertical transmission, and they want to know what age they should start screening infants for
Yeah,
B.
yeah.
I hate to say this, I don't know. I don't do pediatrics. I would think that you could screen them whenever you think that they're away enough for mom. No infants or kids who are carried. Not I was reading what somebody wrote or something. I'm sorry. I don't know that I answered the person's question. I think you would wait till like 1 year or something like that, but I honestly don't know the answer to that.
Not infants, kids who are carriers.
Yeah, I don't,
Okay, that's fine.
sorry.
I think that'd be a great e-consult to submit to one of our pediatric
Yeah,
volunteers.
yeah, uh, 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 for kids who are carriers, how do we follow them and at what age? Um, I don't, kids who are carriers. Okay, so, hepatitis B, like I said, is pretty complicated. You will see people who are surface antigen positive, DNA negative, normal LFTs, surface antigen positive, DNA in the millions, LFTs normal, and we call them immune tolerant. You see patients with surface antigen positive DNA of 2000, but they're e antigen negative, e antibody positive, and they have abnormal transaminase need to be treated. So it's very complicated. And I do not do pediatrics. I got a pediatric hepatologist for that reason.
Great. So we have 1 minute. We'll ask one more question and then we'll kind of wrap up. What amount of Tylenol is the max amount patients with cirrhosis and liver disease should use? A total of 2 grams daily? And what about
2.
the general public? Is it better to limit to 3 grams or 4 grams in total?
Cirrhosis 2 and general 4. But if they drink significant alcohol, okay, it changes the whole thing. Okay, they don't have to have uh they don't have to have significant liver disease to get into trouble from acetaminophen if they drink significant alcohol. Somebody was bringing up the APRI. It's a score that I must admit I don't use. Okay, I love Fib4, and almost all the algorithms that you see out there are using Fib4. But APRI is another calculated calculation done on blood tests that's supposed to give you some idea of the severity of their liver disease.
All right. Well, thank you so much. I think this was fantastic. Thank you all for joining us today and for all the great questions. Dr. Styne, thank you for a great presentation.
And one other thing I mentioned, in terms of consults, most of the time the consults are about a specific patient. I have a patient 37, okay. Don't hesitate